Okay. So our first presenter will be Nicolette. And I've lost the other part of my screen that has everything on there. Sorry. Nicolette Castaneda, who's going to be presenting on the data and reality of the data and the reality, urine cultures and emergency medicine physicians. When you're ready, you can go ahead and share your screen and get started.
All right. Hi, everybody. I'm Nicolette. I'm a PGY2 at Beth Israel Deaconess Medical Center, and I will share my screen. Is everyone able to see my slides? Great.
Yes.
All right. So today I'll be presenting on the data and the reality, urine cultures and emergency medicine physicians. I first like to thank the co-authors of this abstract, Amanda Dudelsack, William Fife, Jonathan Edlow, and Shemai Grossman, who worked with me on this abstract. I have no disclosures. So just some background, as emergency physicians, we're frequently called upon to evaluate positive urine cultures for potential treatment. And this is through a multitude of modalities, whether it be through our primary patients, our sign-out patients, or through QA follow-up when urine analyses are sent reflexively or with concern for possible underlying infectious process. So these are some of the ways we encounter positive urine cultures. There are some very, very clear IDSA guidelines surrounding the treatment of positive urine cultures. They have been published a multitude of times and with significant updates throughout the years. The most recently, I think, was in 2019. And although despite these guidelines, there's a high utilization of antibiotics, so it is unclear if these guidelines are observed or even known. And the IDSA clearly states to only treat symptomatic patients as well as asymptomatic pregnant women, which asymptomatic pregnant women is also being looked over again in, through ACOG itself. So the objective of our study was to elucidate current practice patterns among emergency physicians in treating positive urine cultures within a multitude of different scenarios. This was a cross-sectional design, and we created a questionnaire that addressed 9 different clinical scenarios that we are frequently encountered in the emergency department and are also addressed in the IDSA guidelines. This was distributed by email across hospital networks, our hospital network, including tertiary institutions, affiliated sites, residents, attendings, and associated alumni through our program. The following scenarios were asked about in the survey: asymptomatic young female who is not pregnant, an asymptomatic postmenopausal female, a symptomatic young male, an asymptomatic pregnant female, an asymptomatic elderly female after a fall without urinary symptoms, a confused elderly male after a fall without urinary symptoms, an asymptomatic middle-aged male with an indwelling Foley, an asymptomatic diabetic female, and an asymptomatic renal transplant patient. One of these scenarios is stated here just as an example. So a 27-year-old female presents to the ED with a cough, urine HCG negative, no fever, abdominal pain, nausea, dysuria, urinary frequency or urgency. Her urinalysis and creatinine are normal, or at least unremarkable. Her urine culture grows greater than 100,000 E. coli sensitive to Keflex, ceftriaxone, Augmentin, Cipro, and Bactrim, as well as nitrofurantoin, just as an example. For each clinical scenario, the emergency physicians were asked if they would treat with antibiotics. From the results of our survey, we had 123 emergency physicians that completed our survey. This was about 40% academic hospitals, 38% community hospitals, and 21% small community hospitals. And the respondents are broken down as follows. We had about a 40% response rate. And this is kind of the breakdown in general as to how people responded to these questions. So breaking it down by each scenario and whether or not the emergency physician decided to treat or not. So we're going to kind of go through this one by one just to kind of um, clarify and show kind of what people would do in these scenarios. So in the scenario that we spoke of earlier, an asymptomatic young female that grows E. coli, 34% would treat this patient while 65% wouldn't. It's a pretty significant difference in who would treat it and who wouldn't, and especially when the IDSA guidelines are specifically saying not to treat this patient. Going down, 50% would treat an asymptomatic elderly female and 50% would not. Once again, the discrepancy is pretty striking between who would and would not treat a patient who the IDSA guidelines would choose not to treat. We'll skip the next two because they're essentially 100% would treat them, and they are congruent with the IDSA guidelines. 100% would treat a symptomatic young male, and essentially 100% would treat an asymptomatic pregnant female. Again, we see with elderly female after a fall without urinary symptoms, there's a pretty large discrepancy in who would and would not treat this patient. 63% would treat this patient despite IDSA guidelines saying not to, and 36% would not. Going forward, a confused elderly male after a fall without urinary symptoms, 96.7% would treat this patient, when 3% would not. This is specifically noted in the IDSA guidelines that even patients with delirium or confusion, they would not recommend treating empirically for, they would not recommend treating for bacteria or positive urine cultures in this setting until other sources are otherwise eliminated. For patients with an asymptomatic with an indwelling Foley, 71% would not treat, but nearly 30% would, which is, again, a pretty striking difference to what the IDSA guidelines would say, which is do not treat. Once again, about a 50-50 spread in an asymptomatic diabetic female, where the IDSA guidelines would not treat this patient. And in an asymptomatic renal transplant patient, nearly 100% of respondents would treat this patient. And the IDSA guidelines, again, specifically says that they would recommend not treating a patient like this. There are multiple limitations to our study. It was a small sample size, about 123 respondents, I think, altogether, with a 40% response rate. Our data was drawn from a single network of physicians with a background from limited residency programs. Most of our respondents kind of funneled through our residency. The 9 scenarios are very specific and may not represent the totality of clinical presentations, despite, our attempt to make them as broad as we could. And then these scenarios also imply urine cultures are either reflexively sent or sent with a concern that there is that it could grow possible bacteria, and it may not be representative of what is actually practiced in the communities. So in conclusion, in a survey of 123 emergency physicians with varied levels of training and practice settings, there was significant variation in how emergency physicians chose to treat non-pregnant asymptomatic persons despite clear IDSA guidelines. And we recommend that further research be employed to evaluate why physicians have such distinct variation in practice and how we can better standardize our care for patients to support these well-established guidelines. All right. I'm happy to take questions.
Thank you very, very much, Dr. Castaneda. Yes, you can go ahead and unmute and ask a question if you have one, or you can drop it in the chat. 2 minutes.
I have a question. This is Patrick Marr. I'm up at Mount Sinai in New York City. I was wondering, in your study, you seems like you reported urine culture results, And of course, in emergency medicine, this isn't something that we always have access to, given that culture results can take a few days to come back. You know, I wonder, had you considered reporting your analysis results instead, since that's more often the decision that we have to make our antibiotic prescriptions based upon them?
So that's a great question. I think that, obviously, we make decisions based on our urinalyses, and bacteriuria based on the definition from the IDSA guidelines is specifically defined as as bacteria that's been grown in a culture medium. So I think that that's another thing that we should definitely look at more carefully, and looking at urinalyses. I don't think that I'm not sure that I can't really respond to the data that's out there regarding urinalyses at this time, but this was driven specifically from one of our QA concerns, because we do follow up our own QA, and we'll get these cultures that come back positive. So I think that this is kind of driven from a QA standpoint. So I think that that's a great question, and we should probably further look into that.
Yeah, just to further elucidate, I primarily asked because actually your study is similar to something that I'd considered doing myself, and congratulations to you for doing it. But I had wondered, for instance, about some of these urinalyses in particular, where the results are not as clear as a quantified urine culture sometimes can be, with greater than 100,000 E. coli. That's pretty obviously positive, but sometimes the urinalysis are less black and white.
I agree. Definitely in practice, I think that it's very gray. It's a gray zone, and I think whether we think about these as dirty catches or the urinalyses do show significant white cells, it's difficult to try and figure these out.
Absolutely. Thank you. We have time for one quick question. So you've done this work. Where do you see yourself taking? What's the next step for you with this data that you've collected?
So we also, I think that we need to further elucidate, obviously, why this is going on. And I think we'll probably look at, we're going to look at further what people use to treat these patients with. Actually, Dr. Dudelsack, who's on the line right now, she'll be presenting later this week for what antibiotics we choose. And I think that we're going to have a kind of a follow up and figure out, why we're going to follow up and see why we choose to do the things we do.
All right. Thank you very much, Dr. Castaneda. That was a very good presentation and good information. All right. Our next presenter will be Dr. Dickerson, presenting on trends in urinary catheter use in the United States and U.S. emergency departments from 2002 to 2015. All right. Dr. Dickerson, welcome.
Hi, thanks so much. Is there any chance you can make me a co-host so I can share?
Let's see. Holly, are you able to do that? I can't. It's not one of my powers right now. Holly, can you hear me? When you try to share, it says you need to be a co-host.
Yeah, it says host disabled participant screen sharing. I think I may have come in on a different device earlier, so I messed her up.
No, yeah, and I thought that we had
I just messaged Holly, so hopefully she'll get back.
Thank you. Well, we apologize for that.
My fault, sorry.
Yeah, I'm not sure how to. Can you try it again?
There we go. Got it.
Okay.
All right. Okay, so thank you so much. My name is Katie Dickerson. I am a PGY1 at the Harvard Affiliated Emergency Medicine Residency, Mass Gen and Brigham and Women's. And today I'm going to be talking about how we've used catheters and how it's changed a little bit over the years. Unfortunately, I have no relevant relationships to disclose. So catheter-acquired urinary tract infections are the most common nosocomial infection. It is estimated in several studies that between 15 and 25% of hospitalized patients receive urinary catheters. And it is thought that 75% of the urinary tract infections that are acquired in the hospital setting are from these catheters. This adds up to a big cost. So about 500,000 annual preventable infections, over 8,000 deaths per year, with an estimated cost per infection of about $14,000, adding up to $6 billion in cost to the healthcare system annually. And because of this, there have been several large organizations that have done policy measures to address catheter-acquired urinary tract infections, including the CDC, Centers for Medicaid and Medicare, as well as ASAP actually endorsed a Choosing Wisely initiative to look at this particular problem. The largest sort of landmark guideline that was ever developed was the CDC guidelines in 2009. They're still referred to today as kind of the forefront of preventing CAUTI. And so that actually is going to be used a lot in our methodology, and I'll talk more about those CDC guidelines. So the research questions we wanted to look at are: how has urinary catheter use changed as a result of these policies? And have potentially avoidable urinary catheters decreased over the study time period? In order to answer this question, we looked at the National Hospital Ambulatory Medical Care Survey, or NAMCS. This is a very large data set, which we performed a secondary analysis on, but it's a weighted 4-stage probability sample that looks at between 350 and 400 general and short stay hospitals each year. This excludes federal, military, and VA hospitals, but otherwise, any hospital is game to be tagged for the survey. They do a chart review to determine the data set, and then we took a look at their larger data set over those years. Our primary outcome that we looked at was the placement of urinary catheters, as well as potentially avoidable urinary catheters. And how we qualified this was based on those CDC guidelines that I mentioned earlier. So an appropriate diagnosis by ICD-9 or 10 code, or a disposition. So if someone went to the OR or they went to the ICU, that was considered an appropriate disposition for a catheter placement. We then calculated the biannual rates of urinary catheters and potentially avoidable urinary catheters, doing a subset analysis for admitted patients to see whether or not people in the ED versus people who were admitted had different results over that time. And all of our analysis takes into account the very complex weighted survey design. And this is what we found. Just as a kind of graphical representation out the gate, over the time period that we were looking at, you'll notice that catheter usage really does decrease. And we have the percent visits here on the y-axis, as well as time here, and their biannual rates, as I mentioned. So there's a fairly linear decrease over this study time period. A couple other things I wanted to point out from this is you see these are overall ED visits with urinary catheters placed, and the gray line is ED visits with potentially avoidable urinary catheters. And you see that actually the difference in this over this study time period really is coming from these potentially avoidable urinary catheters. And so what has decreased in this time period is less the catheter usage themselves and more these avoidable catheters. And then, as I mentioned, we did this subset analysis for admitted patients, and you see that admissions with urinary catheters decreases similarly over this time. And again, it's the avoidable catheters. So this orange to this yellow line, the avoidable catheters that's decreasing at a rate that's then reflected in the overall catheter usage. For the numerical among us, there was a 50% reduction in urinary catheters over the study time period. We went from 2.61% in 2002-2003 to 1.37% in the later study period, 2014-2015. And as I mentioned, the primary decrease really does come from potentially avoidable catheters. However, 2/3 of urinary catheters continue to be potentially avoidable. And you can see the numbers there with statistically significant confidence intervals. We did some more analysis on this data. Some things I just wanted to highlight, which I don't go into too much just due to the constraints of time in this presentation, but if you were older, if you were female, or if you were in a non-urban setting, rural hospitals, those people were much more likely to get urinary catheters placed in general, with kind of an appropriate or expected percentage of those being potentially avoidable urinary catheters. Additionally, there were some diagnoses that were associated with potentially avoidable urinary catheters. And this was very interesting because it changes quite a bit over time. So I'd like to highlight in particular CHF, which you could sort of make an argument that perhaps in the ICD-9, ICD-10 coding system, fluid and electrolyte disturbance and other lower respiratory disease could possibly come into CHF, in that I think for patients with hypervolemia, we used to treat, or pulmonary edema, we used to treat more with urinary catheters, but since 2002, those have fallen much lower on the list of things that are potentially avoidable catheters. And so that is just an indication that perhaps how we treat individualized clinical issues and how our practice changes over time really does have an impact on overall urinary catheter usage. Another thing I'd like to point out here is abdominal pain is a tricky one. So in this data set, you can look at up to 5 ICD-9, ICD-10 codes. And perhaps there are certain cases where someone comes in with abdominal pain and it's thought that it may be secondary to urinary retention. That's just never documented or never coded. And so someone gets a Foley in place, but it is unclear. And I think we'll talk a little bit more about that and the limitations of the study, but abdominal pain in general was one of the higher reasons that someone would have a potentially avoidable urinary catheter placed. So some limitations, as I alluded to, the data itself, the NAMSES data set comes from chart review. It's experts that go through these hospital records and pull things like coding. And because of that, some things get lost, and the granularity with which you can look at data is not always perfect. Additionally, in some of the years and in some of the hospitals, straight cath versus indwelling Foleys were difficult to discern. There's only one Foley variable. And so if someone had any Foley placed at all during their stay, they usually were classified as being Foley, but it's not in some hospitals that wasn't the case. And so we may have missed out on some straight cath or thought we were looking at more indwelling than we were. Additionally, this idea of appropriateness was hard to discern because, again, we're using ICD-9 and ICD-10 codes. So I think I would say to this, for trends and looking at data over time, I think this is a very useful data set and a very useful methodology to do it. But I'm not sure that this method would be applicable to a case report or a case review on an individual basis, because we don't always get the granularity that we want. And that leads me into future directions. So I think it's really important to have a benchmark for quality measure reporting, particularly because now some of the hospital's money is based on how many catheter-associated urinary tract infections they get. And I think over time, these benchmarks should change based on clinical practice. I also think there should be further granularity in the survey design for catheter placement itself. And there's certainly room to grow in that area, looking at a survey that was specifically for catheters rather than for most everything. And then I just wanted to throw this idea out, how is it that we change clinical practice? Does clinical practice change invoke guideline development, or do guidelines really matter? And you see from our data that there's this very linear decrease across, including that 2009 time period. And I just wanted to throw out as more of a musing, what are the levers that we use that change clinical practice for a large number of practitioners and really have an impact on these issues? So some takeaways, potentially avoidable catheters certainly decreased significantly between 2002 and 2015. However, the majority of urinary catheters continue to be potentially avoidable, and changing practice for these individual conditions does greatly impact the overall placement of urinary catheters. Thank you so much for listening. I also just wanted to give a shout out to my mentor, Andrew Chu, who really talked me through a lot of the large data analysis for this study and was very, very helpful, and some references here then.
Thank you so much. That was a great presentation. The floor is open for questions. So you had mentioned the kind of the drawbacks of using this large data set to try and make these inferences, but it is clear that over time the catheter use has decreased. What are your thoughts as to effective interventions to truly get at if the clinician felt it was indicated, to add some, I guess, some context to the ICD-9 code, ICD-10 code, which always doesn't capture exactly what the clinician was thinking at the time they made the decision?
Yeah, I do think one sort of benefit of the data set is that you do get 5 codes. And so oftentimes I think if a physician places a Foley, there will be a code that is reflective of that in some way. And also disposition is huge. That's a very large number of people who get catheters placed are going to the OR. And so I do think in that way we capture some of the physician's thought. But you're right in that we don't always. And I think I was trying to hint at that in the limitations of the study. There may be cases we get where we just didn't get the right code, and it would have been classified as avoidable or as an appropriate urinary catheter if we had gotten the right one. But I do say, as a step back, looking at the trends, we are seeing these big changes. And as far as what is a good way to do that for the individual provider, I do think these guidelines play a role. I think pressure from the hospital system, unfortunately, plays a big role. And if you're going to get hospitals that are going to get charged for CODIs, then they're probably going to have some pressure on you too. But yeah, I'm not sure. I think that our practice really started to change because I think providers wanted to prevent infections. And then I think the CDC had a guideline that was released. And so I think it's more complicated than these big organizations telling us as providers what to do. I think there are more grassroots kind of flavor to it.
Absolutely. Thank you very much. That was a great presentation. And
I had one more
agree
question, if possible.
Okay, we have, yeah, really brief.
Really brief. If I understood correctly, you mentioned that catheter use, we see more use with non-urban settings, so rural settings. And I just wanted to know your thoughts on why you thought or why you saw that, if it was a lack of knowledge with the physicians that are in rural settings, a lack of education and whatnot.
So I've spent a lot of time in rural settings through medical school. And I have to say, I never think it's lack of knowledge. That is never the right answer. I think oftentimes it's resources. So when people are strapped and that patient, especially there are some more diagnoses that come up more frequently in here that I just didn't talk about, but things like alcohol use disorder. If you have one nurse that's, running a unit, I think if somebody has to pee all the time, it's really hard. And so you get Foley's placed for convenience, which is completely understandable in different settings. But I do think that may have played a role in why the data sort of skewed towards rural versus urban.
Thank you.
Thank you, Dr. Dickerson. Our next presenter is David Chu in here. I don't see him on the list. Or somebody presenting on his behalf. Dr. Greaves, are you in? Or somebody presenting on Dr. Greaves' behalf?
Yeah, I'm here. How's it going? Do you want to start?
Yes, it looks like Dr. Chu is either running late or will be joining us. So if you're ready, that would be great. So Dr. Greaves will be presenting on fluorescent tracer and personal protective equipment training in the era of COVID-19 And this is a Simulation Academy sponsored abstract.
See if I can do this successfully here. Try to share. Are you guys able to see my PowerPoint? I'm actually. You guys
Yes, I can see it.
because I can't.
Hmm.
All right, great. That's much better. Okay, so first of all, you already gave the title. This is an essay and presentation. This is kind of a little bit different. It's more of a QI kind of twist on things rather than a straight research project. But we'll go ahead and talk about it. So a lot of authors here. I want to, big shout out to my mentor, Dr. Hughes. He's the simulation director here at Florida Atlantic University. We've collaborated with the University of Arizona as well as Indiana University for this project. No disclosures. If anyone wants to let me have some, that'd be great. So, all right. So, the impact of communicable diseases has declined in the past, several decades, but the global burden of communicable diseases is still quite staggering when you think about it. There's millions of deaths annually from infectious disease, and lower respiratory tract infections are actually the 7th most in the United States and one of the highest globally. This is obviously pretty important these days with the current coronavirus pandemic. Ultimately, this has resulted in many deaths for healthcare workers. It's actually completely unknown what that number will be, and it'll likely take years to finally determine that. PPE use is essential. I think we all know that. But it's interesting when you look at the literature, a lot of practicing physicians don't have formal training. Either they had graduated previously and didn't get training in residency, or it hadn't been updated, or there weren't any refresher courses that occurred. A lot of it's just kind of on the job training, but no one's gave them a formal training other than like a PPE, N95 fit test, which doesn't really count. So the question is, how do we get to PPE Zen? How do we get to the point where we know how to do this properly? And we'll go from there. So this is, again, more of a quality improvement project, but was focused on trying to improve resident knowledges and techniques for using PPE. Our thought is that if you give formal training, it'll likely be more effective, but we wanted to use a fluorescent tracer in order to try to provide that real-time feedback. We're going to kind of talk about how to do that and what the methods were used for this training. We'll also talk about some of the results that we found. So this research has actually been presented kind of to the public. There's been 20 different news outlets talking about this, like Don Lemon and whatnot. I think the point I want to make of this is that when you see the contamination, it captures the attention of people. So whether it be the public or whether it be the people being trained, it makes your presentation more effective. And that was kind of, I guess that makes sense anecdotally, right? So kind of continuing that, how do we do this? So the way you do it is really easy. Just take a non-toxic highlighter refill, you dilute it in some water, and it makes it, when the dilution effect actually makes it so that to visible light, as you can see on the left, you can't really see it when it's contaminated, but when you put it under ultraviolet C light or black light, you're able to really see the level of contamination. The way we did the study design is it's a prospective observational study of QI measures implemented in introductory residency training. There's 3 phases of this. Essentially, the first phase is participants had a survey that they fill out to establish a baseline understanding of PPE usage and previous training. And then after that, we had them don PPE, in whatever way they wanted to do. We took video data of that, and then they performed a simulated CPR with a BVM that was covered on a mannequin that was covered in non-toxic highlighter fluid. They did that for 60 seconds each person. They rotated around, and then after that, they doffed their PPE, and then they were checked for contamination. Phase 2 is just a formalized training, which is just simply reviewing CDC training videos available, as well as the techniques and guidelines that are recommended. After that, it was kind of the reverse of phase 1. Same situation, just the last part being a survey at the end. That generated 3 sets of data, basically the contamination data, and then the technique data, which is the review of the video data, and then the survey data. This is kind of just a generalized picture of training, right? You have your mannequin. We use the iStan from CAE Industries for ours. And basically people were in PPE. We didn't use these exact setups here. We used a slightly different gown, but in general, these are pretty similar. After that, we assessed contamination is defined as discrete areas of fluorescence approximately half a centimeter squared, and then areas of fluorescence separated by greater than 3 centimeters were considered a separate and discrete area of contamination. There are 2 independent assessors used to judge contamination using fluorescent, and discrepancies were discussed and adjudicated among independent observers, and rarely we would have a 3rd independent assessor involved if deemed necessary. So let's get into the data here. It's 48 resident single center, mostly QA based study. So there was a focus on what we did is people who are undergoing their ACLS training were enrolled. There was a decrease in the average areas of contamination with training, about 2.5 number of contamination, 2.5 points of contamination per person beforehand versus less than 0.4 afterwards. The contamination is actually kind of, when you actually look at people under black light after doing a simulated CPR, almost all of them, 81% of residents had some form of contamination before training, and then afterwards they had that dropped significantly, statistically significant, less than 0.01. The most common was the wrist, actually. A lot of this has to do with people not properly doffing their PPE and when they take their gloves off, and then also ensuring that the wrists are covered properly and pulled up over the gown. Almost half of the contamination occurred at the wrist, and that decreased significantly after training. Of note, one of the interesting things when you look at the data is that if the wrists were contaminated, or I should say, if the face was contaminated, they usually had wrist contamination, and that was, associated statistically. And that makes sense both from a percentage standpoint. If that's where they got contaminated, they're likely to contaminate other areas, but it also makes sense from a kind of just sheer logistics standpoint. People touch their face with their hands, and the wrist, if it's the most common, might be the place that they didn't clean after, using hand sanitizer. So make sure you go up your wrists when you're washing your hands. You can see this kind of graphically. If you were to take the scores of putting on and taking off equipment properly, when you review that video data, you see that most people make their, made a lot more errors pre-training versus post-training. That seems to play out for the variety of residents. Ultimately, doesn't seem to be a huge difference. There's heterogeneity that exists post, but not pre, suggesting that there is kind of an alignment of the techniques for putting on PPE after training. There really isn't any difference between types of residents. Everyone basically was not good at putting in PPE before training and became better afterwards. The survey data is kind of interesting. I think that this would likely change if this study was repeated because of the uniqueness of the effect on medical training because of coronavirus 19 pandemic this past year. 2/3 had training beforehand, and only about half had hands-on training, and only a quarter had COVID specific training. So a lot of people knew that you had to wear an N95 mask, but may not have been as familiarized with the different types of PPE and what they may mean depending on different contamination precautions. Many of this may be due to the fact that many stopped their clinical rotations because of coronavirus 19, and actually only 15% of the participants had some sort of clinical exposure in the past 6 months prior to residency. A lot of them had a variety of different places in the United States and internationally, and a lot of them just stopped doing clinical rotations, both from a limited PPE standpoint, but also to try to protect their medical students. So a lot of them had like virtual types of rotations and things that wouldn't allow them to practice this. When you look at it, most of the people felt that using the fluorescent tracer was helpful and that this was the primary beneficial aspect to the training. Only 4%, it's not listed here, but only 4% didn't feel that the training had any effect on their use of PPE moving forward. They felt like it was unnecessary. Overall, there was a pretty positive feedback from the training. Obviously, there's a lot of limitations to this. It's one center, it's only 48 residents. It only included residents, and as we know more now, COVID is mostly isn't necessarily foam transmitted as much as, say, the aerosol droplet transmission. So that wasn't, we didn't aerosolize the tracer. So for, because mostly health reasons and logistical reasons, but that would probably be a better study if you were specific for coronavirus 19. Also, we need to figure out how often this needs to be repeated. As I'm running out of time here, I mean, basically, it doesn't matter if vaccines are produced rapidly, PPE is still going to be the most effective. Residents need PPE training, and using fluorescent tracer makes it better. I'm here to take any questions that you may have.
Great presentation. Yeah, the floor is open for questions.
A quick one. There is actually a commercial product which is made for this purpose called GlowGerm. I reviewed a paper, I know, where the similar kind of crew had used it. Did you guys consider using any kind of alternative product other than the highlighter fluid? I just wonder, the GlowGerm, I know, brags that it's made with like little tiny microparticles, and that's why it more closely simulates transmission, something like a droplet transmission. I don't know if the highlighter is gonna treat itself the same way.
Yeah, I know there was the APIC 2016 article talking about GlowGerm and its use. We considered it. We've used that in the past. I don't think that it's possible that there's some differences between it, and maybe we should repeat this study using different fluorescent tracers moving forward.
You kind of alluded to it in your limitations, talking about the time interval for retraining. But real quick, what was the interval between training and assessment for the post training?
So all of this was done in the same ACLS BLS PALS course that was done over a 2-day period. So the interval was no greater than a 48-hour period. Basically, we're trying to kill two birds with one stone by allowing people to get their ACLS training and ensure that residents had some formal training on how to take care of COVID patients. We've had a ton of COVID down here in Southeast Florida, so we wanted to make sure that all the residents had some form of training.
Mm-hmm. And is there any data out there on like retention, like 6 months from now, if you get them to do it again without any retraining, like how many of them retain?
So I actually only know of one paper it's been a while. I don't remember the year of it, but I believe it was over 10 years ago, looking at sort of retention of various training, but it wasn't necessarily specific in the healthcare setting, but I don't think it was specific for PPE. I'd have to review the literature a little bit closely as we're working on this paper, but obviously we know that there's a certain that the data suggests that kind of sequential reinforcement of whatever training you have over a period of time helps keep your baseline elevated.
Yeah, I don't know if you have plans to reassess these folks, but it would be interesting to see over the time period between did they retain it. I know it's probably contaminated by the fact that we've been dealing with COVID, and so they've probably been having to use it, but it'd be interesting. Yep.
We still have plenty of COVID cases down here, so it may be contaminated by that fact. Good pun there, but ultimately we're planning on repeating this for both incoming residents as well as those that have already participated.
Absolutely.
Thank you.
Any other questions? Well, I want to thank everybody for participating in this session. Really great presentations and discussion, and continue to do the good work that helps to move our specialty forward. Thank you. This concludes our oral abstract session. Anantha, thanks.
Yeah, no problem. I didn't really do much, but I appreciate.
Oh, no, absolutely. It was helpful.
All right, take care.
Bye-bye.